Welcome to the Dr. April Jasper Show, relevant conversations for business owners of today. We are proud to be sponsored by ZEISS. ZEISS has been a partner in our practice for so many years. We appreciate all of their innovation, their attention to bringing us new products to bring value to our patients. We're thrilled to have our new OCTA with the ZEISS 6000 in our practice. It has already been a tremendous asset to our practice. Our patients love it. Now is the time to invest in technology. Hi, everyone. Welcome to the Dr. April Jasper Show, and I'm joined today by Dr. Bryan Rogoff with ZEISS. Hi, Bryan.
Hello. Hi, April. Thank you so much for the invitation.
I am so glad you're here. This is a fun day because you took the time to join me in my office, and so everything you see here behind us is in my practice, and this is what patients see every day. What do you think so far?
This is a mini customer experience center like we have back in California.
I love that. And you know, I didn't even dress it all up for you. I know that to me, listeners, viewers, they know that for us in our practice, it's really important that it always look amazing. We want them to feel like when they come in, it's high touch and we bring value to them. And I really feel like the technology speaks for itself, but I want it to look good all the time so they know. Sometimes I say I got a BMW right here behind me, you know?
Rolls Royce, I think they like better these days.
Okay. There you go. So as we talk about technology, what we're going to do, all of you that are listening and watching, Bryan's going to ask me some questions. I certainly am not a retina specialist. I'm certainly not a teacher. But Bryan, I at least know what I do in my practice, and I know how to take your technology and turn it into what works in our building. So we want to make this real for everyone that's listening. And there's honestly, one of the things that we're going to do in a minute is tell you about something really new, hot off the press, and we'll get to that in just a few minutes as well. So don't leave until you hear that. All right. So Bryan, anything that you see that you want to ask me about, anything that stands out to you about the office, or maybe just how do we do things? I don't know. You take it from here.
So let's start off with how you do things. First, come into your office, beautiful office. I know that you have a comprehensive list of different services you offer patients, which in ZEISS now we are referring to as workflows. Basically, if a patient comes in for a particular service, they're going to start at the front desk or even schedule, and then they'll move and come on into the office, check in. Then your technicians are going to be doing a bunch of pre-testing work that we know that is done by not only optometrists, but ophthalmologists worldwide, globally.
Right.
And then you get that data, you're performing some tests, and then the patient moves on. And of course, then has certain types of follow-up schedules after that, depending on that workflow or the disease state. So let's first maybe discuss what kind of services or workflows that you provide for your patients.
I love that. You know, in the past, I didn't really think of it that way, but you're right. In order to be efficient, my team has to know when a patient comes in, say for a comprehensive eye health evaluation, and we do those annually, or at least tell our patients we highly suggest they have those done annually. So now a patient comes in, that's what they're scheduled for, which that's a whole nother topic, isn't it? Because sometimes they're scheduled for the wrong thing.
Of course.
But let's just say that's what they're scheduled for. That's what they think they're coming in for. It's a comprehensive eye health evaluation. What we're going to do with our patients, they sign in. We've already told them about insurance copays. Those are the details you want to get out of the way. They pay their copays, and we get them started. So we have all of our technology in 3 different rooms. The room everybody's seeing right here, everybody is in this room. Mm-hmm. And this room has in it our visual field technology, which you can see behind us. And oh, by the way, what I love the most about that is the liquid lens. That is incredible. So good to not have that box of lenses tumbling everywhere. Did that ever happen to you?
There's many times I've had to just get rid of that, yes.
So that's one of the most fun things. Oh, and the other thing I love about the visual field technology is that it tells my team, my technicians, right there on the screen what to say to the patient and then what to do every step of the way. So that's just the technology piece that my team likes. That doesn't even get into workflow analysis, does it?
No, that's just one piece.
Right.
So you have 2 other pieces here.
Yep.
So talk to me about, you have the Claris, and you also have here the new
ZEISS 6000 with OCTA. And we're loving
Yes.
that too.
And I think you just purchased this not just a couple months back.
Yep.
So you had a previous OCT, I imagine. And so what made you want to get into the ZEISS 6000? And what was your previous OCT that you had?
Yeah, so we had a 5000, a ZEISS 5000 before, and it was a great machine, great technology for its time. But I'm always one that wants to have the latest and greatest. I think it's a great idea to have the OCTA. Everybody needs that. But high definition is incredible. Wide field, I mean, we all went to wide field retinal imaging. It's time to go to wide field OCT. And then also speed of acquisition. Holy cow, it is fast. And then you got to think about the reference database. I mean, Bryan, I don't know how you did it, but for you guys to put in all of those reference points for me to be able to look at and use, it makes me a better doctor. It helps me to take better care of my patients. And it's just been a joy for our whole team. Our team learned how to use it in seconds. I mean, I kid you not, moving from the 5000 to the 6000, they didn't blink twice. It was so easy for them to learn how to utilize the new technology, and the training tools that ZEISS has have been incredible as well.
Excellent.
All right, so the Claris, everybody's going to have wide field retinal imaging, and
So that's included in comprehensive health exams.
if they come in for a comprehensive eye health evaluation and they're paying out of pocket, so they're paying cash, that's part of what's in our technology. That's part of what's in our exam, as well as a screening with the ZEISS 6000.
Okay.
Now, if they come in with insurance, the insurance does not typically cover that as part of the exam, although there are some vision plans where if you have a patient who's diabetic, then pictures are included. So make sure that you look at those specific
Yes.
plans, because that's money that you're leaving on the table. So if they come in, though, and they don't have coverage for that, that's something we present to them right away. 95% of our patients want to have that wellness exam. They want to have that screening because they appreciate the fact that it's going to help us to be able to pick up things that we would never see with my eyes.
Excellent.
I kind of hate to admit that, but it's reality. And I'm totally fine with patients knowing that it makes me a better doctor to have the results of the technology you see in this room.
So besides the comprehensive routine
Right.
wellness exams that you normally do, what other services or workflows do you provide for patients?
Yeah, so I guess the big five, right? So the big five are going to be glaucoma, diabetes, then you have macular degeneration, you've got dry eye, and I throw the other big five in as myopia, because that's something you see all the time. I mean, what we know that the majority of our young patients coming in have myopia. I have hyperopia. I'm one of 5% of the population. Maybe I'm off a little bit, but not much. So those are my big five.
So let's talk about retina. Before we go into how you have your workflow laid out, what the technicians do, and then what you do, and you might view things with products like Forum. I see you have let's talk a little bit with your new purchase of the ZEISS 6000 with Angioplex that does the OCTA. So
Yeah.
maybe go into a little bit how you're using it, what patients that you're using it for. When you start to think about, we always have to think about how reimbursements are going to happen, and those are certainly changing. So discuss maybe how you're operating those workflows with your retina patients.
Right.
And maybe we can go into a little bit more of how that might change for 2025.
Ooh, we promised them that. So we'll wait till the end. That way they all stick around, Bryan. All right. So let's see. I want to tackle this in a way that makes sense and the way it kind of rolled out for me. So the first thing I think about is that I want to be able to determine if there's anything going on with the retina that I wouldn't be able to see. And what I like to do, Bryan, is we capture the images. We take the patient to the exam room, and then that is the first thing I look at. And I actually look at those results in my office before I go in to see the patient, because I don't want to walk in and see something terrible and then have that surprise shock look on my face in front of the patient. So we capture the data, and we want to know that there's nothing going on. And with OCTA, here's the thing that even with a condition such as central serous, in the old days, we had our OCT image, which was fabulous. But to have OCTA, now I can truly determine if there's a neovascular membrane or if it's just fluid. It's incredible the difference it makes to have that additional technology and that additional ability as part of your OCT capture. The other things I think we have to think about And I love that one of the things you guys did when we brought it in is one of the pieces of advice that you gave me was to make sure you look at a bunch of normals. So test everybody you can possibly test, run it on everyone in your practice, have your normals. But what you guys have that I don't know that I've ever seen done before and is amazing is a ton of already data points in the machine.
So we had to run a much larger normative database recommended by the FDA that also had to constitute much more of the population, which is something that they're going to be requiring. So as we look at the population here in the U.S., the demographics are made up of Asian Americans, African Americans, and so on and so forth. So our database is close to 900 patients to what previously what we used to have to do is about 400. So it has almost double the reference database in the ZEISS 6000 now.
That's incredible. I mean, I could get lost in just going through it. Other people get lost in social media. I get lost just looking at all of these images that you guys have put in the library. I call it a library. You call it a reference database. But to be able to have all that. Oh, and here's something I love, which I think people get worried when they buy new technology that they're not going to know how to use it. Do you think that ever comes up? It did for me.
All the time. They don't know how to use it. They don't know how to. They just try to get the patient in there, try to capture an image, and they're hoping that's good enough.
Yeah, and so what you've done, which I love as well, is you've given me the ability with an OCTA image to actually put it on the screen next to my patient's image. So meaning take one of them out of your database that shows, say, a branch retinal vein occlusion. I can put my image up right next to it. I can look at it. And it's real easy for me to be able to see, does this look like that? And I love that you call them the en-face slabs. Is that what you call them? I mean, I first saw it, I thought, what is that? That is hilarious. I don't know. Is there any reason behind it?
That's not me.
Okay. Either way, I love saying it. So to be able to capture those, though, and have them to compare and look at and be able to see that even if I didn't know, now I can have that as a reference to be able to help me.
So are you running OCT and OCTA on all the retinal patients that come into your practice? Obviously, without disease, you're probably just doing an OCT, a 92134.
Right.
And then anything that you might have to bring them back for more retinal evaluation, you're running an OCT and an OCTA with your new ZEISS 6000.
Yes, exactly. And what's really interesting, people ask me all the time, if you do wellness screenings, and remember the definition, as Bryan knows, he's fabulous at teaching this, so if I get it wrong, you correct me. The definition of a screening is it has to be done before the patient sees the doctor. And so it's not a test that I've ordered. It's a test that they've chosen to have done as a way for me to be able to take better care of them in the exam room for part of that exam.
Yes.
Now, the workflow, though, for a patient who is a known diabetic or a known glaucoma patient, that's a whole different workflow. And that's what you were asking me to talk about, and I got a little distracted.
So you have now medical necessity,
yes,
which then you would put a claim in for the different payers, either commercial or public.
Exactly. And that's really magical because then a patient, what's really amazing as a patient, I would think for me, for you as a patient, I'm sure as you come in, your doctor says, I captured this data. This is what we know you have. The good news is we're going to get you back in 2 weeks. We're going to do a deep dive. We're going to get more information. We'll know then if we need to do anything more. And if it's something more emergent, obviously I won't wait 2 weeks. I'm just throwing that out there as kind of a way we would talk to a patient. But then we bring them back and we can do an OCTA and be able to determine if there's anything more going on that we couldn't see the first time with the regular screener.
This is great to hear as you're running both OCT for the structural changes and OCTA for vascular changes. Now you're running both of those, and we know as of 2024, if you were billing for an OCTA or an OCT, you're using the same code as 92134. Now, with 2025, it's been a couple years in the coming. The AMA went ahead and got a new code and then had to go through a whole bunch of couple RUC committees and all this other stuff that they do. So starting in 2025, there's a new code for OCTA, and that is now, the CPT on that is 92137. So that has a slightly different reimbursement. Also, Medicare has released the final rule. as of November 1st about a change in the conversion factor. It
Yeah.
did go down, as we always understand that's usually what happens.
Right.
We don't know about the commercial payers, but we do know that there was over a 2% change in that conversion factor, which takes down a lot of these reimbursement codes downward.
Yeah.
So the unfortunate part for OCT, there's 92132, 92133, and 92134. Those have all actually decreased, especially the 92134. I think had over a 22% change decrease from about a global code of about $40 and change down to about $32, $33 and change.
Yeah.
They did let us know what the RVUs are. So we know now with OCTA that global code is about $56, $57. So that's a big change. And understanding that you are doing both of those scans on, especially those patients come in for retina.
Right.
But we know that OCTA, we're looking more for vascular changes. And of course, with the OCT, we're looking for those structural changes. How is that going to change your workflow, knowing that you can bill separately on those? And so now you have to pick what scan or what code you're going to use with what patients. Of course, we don't want to do this for monetary reasons, but we know that
what's right for the patient.
What's right for the patient. Now, they also said that you can't bill for a 92133 and a 92134 on the same day as the OCTA code, 92137. However, it can be put in as a separate claim if you're running fluorescein angiography and or ICG, probably meaning that OCTA has probably a good idea if you should be running those tests. As optometrists, we don't, but we have a lot of ophthalmologist friends out there that will be looking at this OCTA, especially the Series 6000, saying I should run an OCTA first before I run my FA.
Yeah.
So I know I spoke quite a bit, but I guess just discuss more on how you're going to have to change your workflow starting to know that these are different codes.
Well, and it's good that you said all that, because first of all, by the way, that was it. We told you we had something special coming, and that was it. So now you know that there is a new code for OCTA technology, and that is going to be effective as of the beginning of January.
Yes.
Now, for most of us, so there will be, and you heard Bryan say it, he said it perfectly, but sometimes people like me don't catch all of those words. So the word you used was global.
Yes.
So he gave you a number that was a global number. That means if you're in Florida like I am, it may not be exactly that number. You have to go look at your MAC and look at your numbers. And it also may not be exactly January 1 for every MAC, correct?
That's right. So Medicare has approved it, and usually the MACs go along with this, and the MACs have their separate ways. They have their own chief medical officers that look at everything, and it doesn't include commercial. We always know commercial payers will typically follow Medicare, so it may not be January 1st for them. It might not even be 2025 for some of them. But this is good to know, because at least once Medicare makes these rulings, that a lot of this will follow suit.
So now let's fast forward to the next question Bryan asked me, and we're going to work on this together a little bit, because that's the point of you being the brainchild behind a lot of this, Bryan, and I'm so glad you're here to help me think it through. But what I'm thinking of as of this point, again, and you gave us the key words, OCT is structural, OCTA is vascular. So anything that's going to have a vascular component, you need to have an OCTA if you're looking for changes earlier than what we used to be able to get those determinations based on just our OCTA.
Yes.
So if you look at how OCTA works, it's actually very interesting. It's incredible. I don't know how people can think and develop stuff like this, but I'm sure glad you have a team at ZEISS that does it, because it gives me valuable information that can change the trajectory of my patient's vision. I mean, take diabetes, for example. If we run an OCTA and we can see changes that will help us to educate them that you may not have visible retinopathy, but I do see this. And so as a result, we need to make sure we get you on tighter control. Their primary care and their endocrinologist are probably not going to understand this right away. So that's a whole nother subject we can talk about, is how to help educate them about this new technology and the results of it. But we certainly can have a deeper, better conversation with those patients right off the bat.
So you spoke of diabetes. We also know that AMD, and we do a lot of OCTA when it comes to neovascular membranes, especially those diseases that cause them.
Right.
But I imagine, especially in the geography where you are, you probably see a lot of other vascular problems that come on in that might be on a patient's case history, but may not have any. They might be in for a comprehensive routine health exam. So would that start to change some of the way of your thinking and your workflow when you use OCTA?
Yeah, and I think, so let's take a specific example. Somebody comes in with hypertension and their blood pressure is out of control, or maybe even has been controlled now but was in the past. We know damage could have been done in the past and may not be resolved or even at the point where we're comfortable that they're going to be okay down the road. Those are patients that we should start to consider. And I love the idea of having my photos, so I have my wide field retinal imaging. And a scenario I can think of is, what if I have a patient that nothing came out on the OCT, but they showed peripheral retinal hemorrhages? Now I really want to have an OCTA done because there could be something going on in the deeper layers of the retina. There could be something going on in the choroid. There could be something I don't see. And I think that's where we all need to change kind of our protocol, is what do we now have a window into seeing that we never had before because we didn't have that ability? Am I thinking down the right path, you think?
I think so. I mean, when it comes to any type of vascular changes, sometimes when there's not the medical necessity to be able to put the claim in,
right,
being able to do the OCTA to understand if there's going to be vascular changes. And I think that's the whole point of having that separate code.
Right.
From OCT to OCTA is to understand there'll be vascular changes before the structural changes.
Right. And it could be there's a patient who didn't see 20/20 and I haven't been able to figure out a reason. I mean, those scare me, honestly. Those are the patients where if it were my mom or my sister and I couldn't figure it out, that's when I would typically refer. And here's what's really cool about this technology too. I believe it's going to help us be able to take care of more patients here in our practice that we were sending out to clog up the whole process at the retina specialist. And I love talking about collaborative care. To me, it's such a huge problem that we send patients sometimes that don't need to be sent, takes time and energy away from them, and then the retina specialists have a patient there that I could have handled had I had the technology to do it.
We hear that a lot from our colleagues, ophthalmologists, when we understand how to improve their workflow as well. It's being able to have a much better definition of where we should be ending our care and where they should be beginning, and not to have that overlap where if it's something that optometry or even general ophthalmologists can handle before they have to go into the specialty of retina.
Right. So I think as you look at that patient that you said walks in the front door, they come in for their comprehensive eye health evaluation. We want to take and we want to get measurements on them as a baseline. Now they see me, and I'm the one that's interpreting the data. Of course, the doctor is so important in the whole part of this. My team captures it. I open it up on the workstation in the exam room. I show the patients what we're looking at, and then I tell them where the missing parts are. I'll tell them, I don't know about this because I haven't run this test. We need you to come back. And what I think has worked really well for me, Bryan, is on that return visit. That's when I'm going to do things like we're going to run the OCTA, but we're also in many cases going to run a visual field. So since I have them here, why would I not do everything I need to make it fast with CETA Faster? Oh my word, you can do. I'm so old and it looks like he's got the gray hair. I cover mine. But anyway, I'm so old, Bryan. I remember when I bought this practice, my visual field, let's turn and look. Oh, it was at least 5 times that size. Do you remember those days?
I remember those days, and I know that people want us to get it smaller than that these days.
Really? Well, the other thing, too, is it was a much larger box, but it was also, 10 times as long it took to take a test.
Between the new algorithms and just the general technology overall.
Yeah.
The testing is much, much faster than it used to be. And so definitely.
Yeah. One of the things I forget often, though, that really is a highlight, and if you talk about workflow, is when it comes out of your mouth and all you say is, I show my patients the results on my workstation, or, it sounds like a sentence. But to actually be able to click through all the options and show them everything, and it takes 5 seconds, 2 seconds, 1 second, depends on your internet, to pop up the results, then to scroll through your scans and be able to show them, man, we look amazing. And back to what you said, it's not even how good it makes us look, but how much better we're able to care for our patients.
And that's the whole reason why we're now focused on these workflows and understanding all the different services moving along, because it's about efficiencies. And when we hear about the reimbursements, they obviously continue to decrease. We have to work more efficient to be able to keep up with not only the patient load, but also to keep up with supporting the practice and making sure that you have everything that you need to be able to do your job as well as you can.
And what's cool is you can build in your protocols. So I like that you've created that for me too, so that my team, if they forget what I want them to do next, they can go look and they can see exactly what's the next step for this patient who has this diagnosis. And so I think that's the future. The future is we have to be efficient, just like you said. I have to be able to see a patient, walk them through what's going on, increase their compliance with medications and with their next visit, but then be able to reassure them, Bryan, when you come in for your next visit, you're not going to sit here for 4 hours in my practice. We know exactly what we're going to need done that day. You're going to come in, you're going to do it. We're going to look at the results. And I keep pointing this way because I'm pointing at my exam room where they're going to be sitting. But we're going to look at the results together, and then we're going to celebrate when you've done a great job and things are better. We're going to be concerned, but with compassion and care, when things have gone awry. And we're going to talk about how we're going to improve in the upcoming months for every patient. And that's what I feel like technology can help me to do better. It helps me to be me, and the technology helps me to do a better job making sure patients understand the need for them to be compliant.
That's excellent. I appreciate it, because that's the reason why I moved over into medical device.
Yeah, tell us about what you do, Bryan.
So my title is head of global workflow management for the comprehensive side. So that's why I'm asking a lot of these questions about your workflows as a comprehensive physician, because you handle a lot of different things. I say we are the detectives.
Yes.
Where our retinal workflows, our glaucoma workflows, our cataract workflows, they're very specific, disease specific, but also tissue specific. So when we think about comprehensive, we're thinking about, we don't know what the patient's necessarily coming in for.
Right.
The workflows have different tests that need to be done, different jobs to be done. And so I saw this when I practiced, both on the corporate and a private setting. And then when I did a lot of consulting myself, I went into a lot of practices. I saw all the different workflows that they were doing, trying to make them more efficient doing flow mapping, what we think of with Six Sigma. And I realized that for me to be most effective is taking what I've done all part of my career and moving it into medical device, where we can make these devices, we can make the interoperability with things like these devices along with Forum and Retina Workplace and Glaucoma Workplace, and how do we make that more efficient for the doctors to be able to see more patients as we know reimbursements go down. So it's putting it all together.
It's invaluable. What you're doing is what's going to make us shine and make our patients healthier down the road, because it'll increase compliance. And I can't tell you the number of times, and it's not to talk bad about someone else, but I can't tell you the number of times that a patient will come in and say, I don't want to go back to wherever it was again, because I sat there for 5 hours and I don't even know that they knew who I was. I spent 2 minutes with them. They didn't have, and I hear this all the time, they didn't have half the technology that you have. I believe, though, here's what's funny, and this is a lesson for all of us. I think many of the places they go, because I'm not sending my patients to places that are not amazing, they have the same technology in many cases. They just don't take the time to make sure the patients know how incredible the technology is, and how that's the reason that they can take the care they do of them, and how important it is that they come back. Anything you can keep doing, Bryan, that makes us more efficient is so important to me. So thank you, and thank you to ZEISS for having you there.
Well, thank you, and thank you for also using the equipment and also explaining to everybody on how to really utilize it in your practice. It's one thing for us and our salespeople to be able to explain it to fellow physicians. It's another thing to hear from a fellow physician to say, this is how I use it. So thank you.
Do you think it's a good idea for people to be considering up trading? I mean, I think you know what happened in my practice. I knew that OCTA was something that I needed to have, and it was a great time for me to change out my technology anyway. So I did this because I had a feeling we were going to have reimbursement issues, but also because I knew I wanted to have this for my patients. But another reason I've heard you say, so tell me if I'm on track here. I think that when you work with other specialists, the other thing that's important to them is that they want to know that they're sending the patient back and working together in a collaborative manner with someone who has the technology that they can trust. They'll be able to manage that patient. So, I mean, I would think that makes a lot of sense for all of us.
That is one of the goals for ZEISS, is to have that collaborative care, because the patient does go to a specialist, and usually sometimes it's a one-time event like cataract surgery, and then they have to refer back.
Yeah.
Or it might be for the retina specialist where they have to handle that one piece and then send it back to the general ophthalmologist or the optometrist. So collaborative care is one of those things that we are closely focusing.
I love it. So guess what, everybody? Bryan is the one that brought you the news. There is a new code, which I think is amazing for our patients, because it means new technology and a new ability to be able to detect, diagnose, and treat conditions we wouldn't have been able to see and treat as early in the past. So you got it from us, a new code, new reimbursement, but really start thinking about how you're going to apply it in your workflow and how it makes sense. Watch for more information to come out as time goes by, as we
Yes.
have more time, and you put more time into researching it as well and helping us. And who knows, maybe you'll hear from the two of us again. Thank you all for being a part of this. Bryan, you're amazing. Thanks for coming all the way to West
Thank you very much.
Palm
I
Beach.
appreciate it. Yes, all the way from Dublin, California.